Here's an example of what I was talking about. Here is a large cyst associated with the epididymis, and here is a dilated V. testis, cysts associated with the epididymis, and perhaps some cysts actually intratesticular as well. So these are all sort of associated with each other and common to find them together. Again, here is your spermatocele. Spermatocele, another view. And this is the same patient. Here's the mediastinum testis, and there's a slightly dilated V. testis, which is sort of makes the mediastinum thicker and more obvious. Now, the dilated V. testis and the spermatoceles need to be distinguished from the other dilated structure, which is commonly seen around the testicle, and that is varicoceles. Varicoceles basically are dilated veins. There's a pampiniform plexus of veins around the spermatocord and surrounding the epididymis. They generally should be veins that are less than 2 millimeters in size. When they dilate up to be greater than 2 or 3 millimeters, they're called varicoceles. They may be associated with incompetent valves, which allow the blood to come back down. They're more common on the left side than the right side. This may be because of the nutcracker effect of the SMA on the left renal vein and the fact that the left gonadal vein empties into the left renal vein. But in any event, the major significance of these is that they're thought to be associated with male infertility, and the reasoning is because the presence of a varicocele heats up the scrotum. There's more blood flow in the scrotum, there's more body heat in the scrotum, and spermatogenesis requires a lower temperature to be successful. And so with the higher temperature associated with varicoceles, you may have a problem with spermatogenesis. Another issue is that varicoceles, when they become engorged, can actually become tender, and so a patient may present where there's pain in standing up, which is relieved by laying back down, and the pain gets worse with standing and is clearly associated with some dilatation of some venous structures in the scrotum. So varicoceles may be treated for either of those two reasons. An example of varicocele, here's dilated tubular structure in the scrotum, and this is the Doppler flow with Valsalva, showing you that you can fill it with color flow. Now, varicoceles in general are outside the testicle. They're in the pampiniform plexus, which is around the spermatocord. However, there also are intratesticular varicoceles, and here we see an example. This is a testis, and the Doppler shows you there's a dilated tubular structure within the testis, and that tubular structure is a varicocele. And you know it's a varicocele because of the flow, but it's also often associated with extratesticular varicoceles. And when you see the tubular structures inside and outside, they're going to be varicoceles inside and outside. As opposed to, if you didn't see the varicocele outside, you might have thought that was going to be dilated V. testis if you did not have the Doppler flow. Moving along to some other congenital issues that can happen with the testis. Testes are supposed to be in the scrotum. Most babies are born with the testis in the scrotum, but about 3.5% of newborns have an undescended testicle at birth. So that is to say that when they're born, the testicle is somewhere up in the inguinal canal, and it's not present within the scrotum. Most of these will descend on their own, so that only about 1% persist at a year. But the ones that persist need to be treated. They need to bring that testicle down into the inguinal canal, because if we leave the testicle up high, it's going to be associated with infertility, and more importantly, there is an increased risk of testicular cancer with long-term non-descended testicle. Often that's a seminoma is the type of cancer you might find. Another topic talking about painful groin. Sometimes the doctor has trouble making the diagnosis on clinical exam. I feel a mass there. I'm not sure if it's a hernia or not. I'm not sure if I really feel something coming down. Well, ultrasound is a great extension of the physical examination. With ultrasound, you can look at the groin in real time. You can ask the patient to Valsalva or cough, watch for herniation of a structure down into the groin and through the inguinal ligament. You can actually characterize the hernia tissue to see if it's fat or see if it's a little bowel. You always do this examination with the patient standing up, because that's the orientation in which you're much more likely to see a hernia. So here we see a small amount of fluid, and we see this is mesenteric fat herniating down. Once again, this is the piece of momentum herniating down into the inguinal ligament. Microlithiasis is a very interesting topic. It's something that's relatively common, and it's also relatively controversial. So here we see An ultrasound evaluation of a testis. This testicle has one little bright spot in it. But here's another testis, and this testis has multiple bright spots throughout this testis. These tiny little echogenic areas are called microliths, or small stones. There may be an association of testicular cancer, specifically seminoma, with microlithiasis. It's a rather controversial topic. The risk may increase with a larger number of calcifications. In general, when there's more than 5 of these little calcifications, we call that microlithiasis, classical microlithiasis, and we usually tend to ask for a follow-up ultrasound. Although the literature does remain controversial on this, it is unclear if these people really have an increased risk of testicular cancer. If they don't, then the reason that we find all the cancers in these studies that report them is probably because of a population bias in the people who are evaluated with ultrasound, who tend to have both masses in the testicle, and we find the incidental microlithiasis. Doppler flow, the question now is, does Doppler flow help you in diagnosing a testicular mass? Well, any mass that's over 1.5 centimeters in size tends to have flow, so the flow may actually help you see the borders of the mass, where the normal vessels are sort of strung around the mass, but the presence or absence of mass within a tumor in the testis does not help you distinguish what type of tumor that is. More important than Doppler flow is the distinction of whether the mass you're seeing is intratesticular or extratesticular. Most intratesticular lesions are malignant. Only a minority of extratesticular lesions are malignant. Most of the lesions that are extratesticular come from the spermatic cord. We're looking at lipomas, and lipomas of the spermatic cord are often also associated with hernias. Other types of mesodermal tumors are fibromas, and the most common malignancy extratesticularly is the sarcoma. This obviously is an intratesticular lesion, and this is a heavily calcified lesion. We'll talk about the characterization of intratesticular masses in just a moment. So the intratesticular masses are broken up into different types of masses. The most common is the germ cell tumor line, and here we see a testicle where there is a relatively well-defined hypoechoic lesion. The Doppler shows you this well-defined rounded mass, which is hypervascular. This turns out to be a seminoma. 40% of germ cell tumors are seminoma, so it's the most common germ cell tumor, usually well marginated and hypoechoic. It's usually not cystic and not calcified. Okay? As opposed to the embryonal cell lesions, which are slightly less common, they're a more aggressive tumor, and therefore they're not so well defined. They're very inhomogeneous, and they often invade out of the testicle. They will also often have cystic areas and calcifications, which would not be classical for seminomas. Now, teratomas often have a mixed echo texture. They're often heterogeneous. They may have cysts, and they're often calcified. The image that I showed you in the previous slide of the calcified lesion in the testicle, that was a teratoma. Problem is, you can also have teratocarcinomas where the teratoma is associated with a malignancy as well. And finally, a much less common tumor of the germ cell line is the choriocarcinoma, which is a hypoechoic and can be an aggressive tumor. As opposed to germ cell tumors, which were far and away the most common tumors in the testicle, stromal tumors are much less common. They account for only 5% of all testicular tumors. This happens to be a stromal tumor, but there's no way you could distinguish this from a classic seminoma. There are multiple cell types of stromal tumors, the Leydig cell being one of the most common. Of the Leydig cell, 15% of them are symptomatic because of antigen production. The other stromal tumors include the theca cell, the granulosa cell, the lutein cell, the Sertoli, and the fibroblast. So usually they're hypoechoic when they're small, just as seen here. The large tumors can be more complex in appearance, but it's in your differential diagnosis, you're not going to be able in general to distinguish these from seminoma. Now, we said that most of the extratesticular tumors are benign. Epididymal tumors are 10 times less frequent than testicular tumors. The most common epididymal tumor is the benign adenomatoid tumor, and it is actually accounts for 30% of all extratesticular masses. Most commonly seen at the tail of the epididymis. You treat it with local excision because it is possible there could be malignancy there, but they are benign. So once you treat it, that's the complete treatment for the patient. Other epididymal tumors include the leiomyoma, which is a benign tumor of smooth muscle, and a papillary cyst adenoma. Now, an interesting tumor that should be mentioned when we discuss the testicle is lymphoma. And the reason is because The testicle tends to be a sanctuary for lymphoma after chemotherapy. Chemotherapy often does not penetrate into the testis as well as it does to other areas, so you may treat lymphoma in the rest of the body, but still have a small hypoechoic area at the bottom of the testis, looking at it in transverse. This is a hypoechoic lesion. This turns out to be recurrent lymphoma status post-chemotherapy.